So if you don't know, I'm a practicing gastroenterologist at Mayo Clinic in Florida, but as an IBD specialist. So these are two of my colleagues. Dr. Ryan Stidham and I had the opportunity or the honor to be co-faculty together at the University of Michigan. Dr. Stidham is well accomplished not only within clinically managing IBD patients, but he's also somebody who's going to be giving our keynote speech tomorrow talking about artificial intelligence and how do we really either move forward with what we're doing in medicine as well as gastroenterology. He's an associate professor of medicine as well as tenure within the Department of Medicine as well as computational medicine and bioinformatics. So he's really, really smart. But he's going to start us off with a state-of-the-art lecture talking about endoscopy and inflammatory bowel disease. And then Dr. Carr, who is at Henry Ford and is a gastroenterologist also practicing inflammatory bowel disease. She actually previously was the director of the inflammatory bowel disease program there, but now is actually the co-medical director for the Henry Ford referring physician office. And so she's really expanded her roles, being able to care for patients within the community and make sure that you all can get patients within Henry Ford. So I look forward to updates from DDW, from both of my colleagues, and then we'll take some questions. We'll conclude our first day, and then I have a closing announcement, and then we will all get on to that beautiful weather outside. Make sure you don't miss the sunset tonight. It's about 9:15, 9:30. It was beautiful last night. So, Dr. Stidham.
Thanks a lot, Jamie, and hi, everyone. It's especially great to for all of us to get together because we're kind of sharing the same flock of patients and they're kind of all at one point or another moving between each of us. And so I think it's, beyond taking a moment to think about some of these diverse topics, I think there's also some benefit in just getting to know each other personally. I think my slides are auto-advancing, so at this rate we should be done very quickly. I had some disclosures, don't mind them. Is there any way we can stop the slide deck, go to PowerPoint, find where the timings button is and turn that off? I don't have any good jokes. So Jamie, while we're waiting, Jamie was with us for so long, and it was such a loss for the entire state to lose her to Florida. But now I have a home base for all of my Michigan snowbirds, and they're like, "Oh, I'm going to Florida. Oh, I have the perfect person for you." So thank you for that, Jamie, and amongst many other things. We do miss her dearly. Okay. That's Bruce Willis crawling around, poor Bruce in the colon. I found that picture online. I thought it was fun. We'll talk about endoscopy and IBD for the next half hour or so. Some updates for the 21st century and how much of a risk for colorectal cancer and dysplasia does IBD confer. We'll talk about the new trends in personalizing CRC surveillance strategies. We'll talk about random biopsies, chromo, what, when, where, how, why. If dysplasia pops up, what do you do? And personal favorite of mine, stricture management. In a past life, that was what I was doing when I was in the lab. That's how I met my wife, was working on strictures and fibrostenosis. Okay. Cancer and IBD. Let's think about the historical perspective, and it's good to put this in mind and perspective because this is where a lot of our current thinking comes from. Two components have always been thought to confer the additional cancer risk in IBD. One is disease extent. And in studies using data from 1990, 1980, and 1970, some of the pivotal studies in Lancet and New England Journal of Medicine in 1990 kind of showed that historically the extent of disease was associated with the risk of cancer, including an incidental risk of almost 15 times in patients with pancolitis. And there was also an increased risk in Crohn's disease based on the amount of colon involved. And they showed back in the 1990s, if you just have TI disease, your risk of colorectal cancer is actually similar to the general population. The other component was, of course, disease duration. And this is the well-known Eden paper from Scotland, which looked at the UK. And again, this was published in 2001, but used data from 1990 and before. And they showed in this paper that in that era, 70s, 80s, and 90s, the more time passed, if you have inflammatory bowel disease, the greater your risk of developing colorectal cancer. These two components together made the GI community say, there's more colorectal cancer in UC and Crohn's, we should be looking more, checking more, and doing more, and that's why we have this lecture today. But things have changed in the modern era because treatments are different. Colonoscopy is better, our techniques are better, and as a result, the actual risk of IBD and our understanding of that in terms of colon cancer has changed. This is work from Tina Jess. Tina's a very, very nice woman in Copenhagen. And Copenhagen has the luxury of every single one of the million citizens in Copenhagen, all by law, are mandated to participate in their registry. So they have data from 1909 all the way to the present for all medical conditions for their whole little city. This is just in Copenhagen, not all Denmark. And more or less what they showed is between 1990 and 2010, looking at all IBD patients in Denmark, there they found that neither Crohn's nor ulcerative colitis increased the risk of colorectal cancer. That's funny. That shouldn't be entirely true. This is not completely true, but the idea is that the risk is less than it was in the past, and that may change some of our strategy moving forward. So I think the takeaway from her work early on was this idea that the risk has been declining over time. This is a factor of better therapies, better control of inflammation, and probably most important, better surveillance for colorectal cancer. Culturally in Copenhagen, people don't like taking medicines. So the first sign of dysplasia of any kind, they would just do surgeries, and they'd rather have a colectomy than use medication for many people. So that probably is a major reason why that particular population is so biased towards not having as much colorectal cancer. However, in subsequent meta-analyses, one done just a couple years ago, looking at multiple different countries, Sweden, the United States, the Olmsted cohort from Mayo, has confirmed that this is actually true, and that the overall incidence of colorectal cancer has been dropping over time, likely because we're doing a better job treating these diseases. And if you need more proof on this, this is an American cohort, right? And what you're looking at on the left in the box plot on A is different decades and periods of how the incidence of colorectal cancer in UC has substantially and significantly dropped over time. The figure in part B, that's a nice corollary because this is showing that when cancer is detected in ulcerative colitis, it's often being detected in those blue bars in the modern era, which is during surveillance, as opposed to being detected on CT scan or being diagnosed before the colonoscopy. So the point of that other figure is that we're catching this because we're doing more and higher quality colonoscopy. But it doesn't mean that the risk is zero, and it doesn't mean that the risk is not still there. This is work from just this year in the Journal of Crohn's and Colitis from Jordan Axelrod, who's at NYU, I think. And essentially what you're looking at is the hard line there is showing either the detection of polyps, adenomas, or frank dysplasia. And for patients with colonic Crohn's or any type of ulcerative colitis, over 30 years, there's a 2.5-fold increased risk of dysplasia or frank adenomas in patients with IBD compared to those without IBD. And this is a study looking at, in the originating cohort, 41,000 patients with 1,200 of them having some kind of finding, and a matched non-IBD cohort. So Jordan worked really hard on this one. So the risk is definitely still there, okay? And ultimately, while that's dysplasia, there's still an increased cancer risk. So when we counsel our patients, both the increased rate of diagnosis of colorectal cancer in IBD versus matched populations, as well as death from colorectal cancer, is still higher than in the non-IBD population. But that risk factor is lower than it was in 1990. We're looking at risk factors of 1.3 times or 1.6 times. Not the 3, 5, 10-fold increased risk that you were seeing 30 years ago. So this helps us in counseling our patients and understanding the risk, and also in figuring out how much should we be looking for colorectal cancer and dysplasia in our patients. This is a really important paper from Huygens and colleagues. It's in Gastro from about 2 years ago, and it's a meta-analysis of all the risk factors of colorectal cancer and IBD. And this is relevant because these are the individual components that are going to help us figure out how much should we be surveying our patients with UC and Crohn's for dysplasia and cancer. Listed here are the different strong risk factors for the development of CRC and IBD. This is not dysplasia, but the CRC risk. Of course, low-grade dysplasia is going to be a high risk factor because we know that transformation into cancer is there. But there's also colonic strictures. Look at the odds ratio. It's close to an 8-fold odds ratio if you have a stricture, even without dysplasia present, of eventually developing colorectal cancer. We all know that primary sclerosing cholangitis is there, but also family history and extended disease are key risk factors. There was weak evidence for being male gender and increasing age, but that evidence was pretty weak. It's also important to know there's protective factors. Just having one surveillance colonoscopy after diagnosis reduced the odds of eventually having colorectal cancer, as shown here, with an odds ratio of 0.4. This is really just a surrogate that the patient and their caregivers know we should be looking often. 5-ASA use, thiopurine use, and interestingly, smoking were all associated as protective factors. Statin use was a really interesting one, which has repeatedly been shown to slightly reduce the risk of colorectal cancer in general, but in particular in IBD. But the statistical significance is still relatively weak. But these are the different risk factors that we can consider. And those risk factors are translated into, in this modern era where we have better control of disease, we have a lower risk of colorectal cancer, and we have better colonoscopy technology. We're using those risk factors to try to personalize our surveillance strategy for patients with IBD. So here's a chart here. All of you will have access to these slides, so we don't have to memorize this stuff at all now, but basically, I'm showing 4 different society recommendations: the AGA, ACG, British Society of Gastroenterology, and ECHO, the European Crohn's and Colitis organization. All of them are recommending to begin surveillance at least by 8 years after onset, and if PSC, of course, we all know you should begin at diagnosis. But most of the recommendations for how frequently to do that surveillance are pretty similar between the societies now, and you can see the dates of when they made these updates. So who needs an annual surveillance colonoscopy for colorectal cancer and IBD? Primary sclerosing cholangitis, family history of colorectal cancer before 50, dense PIP, pseudopolyposis. If there's a lot of pseudopolyps there, strong risk factor for developing aggressive and early colorectal cancer. And if they've had any detection of dysplasia recently, these are the patients that should probably be having annual surveillance. But some people can get away with every 2 to 3 years. And these are what these patients kind of look like in terms of risk factor association. Some pseudopolyps, but not everywhere. A family history of colon cancer, but not early. Maybe they have ongoing chronic mild inflammation that's been just difficult or unable to resolve. And maybe they had dysplasia in the past, but it's been a while. There's some subtleties in the different recommendations between societies, but these are the overall themes. And probably most importantly, who are the patients that can go maybe 5 years, the longest period of time, without surveillance? These are patients who are in so-called deep remission. So if there's minimal to no endoscopic and ideally histologic evidence of inflammation, these patients can probably go 5 years without a surveillance colonoscopy, and the societies are endorsing this. Again, some modification on what to do if dysplasia has been detected in the past. Some societies make statements, some don't. But these are the general themes here of how often we should do this. So we're moving more now from a one-size-fits-all, everybody needs an annual to biannual colonoscopy if they have IBD, to a more personalized approach based on risk factors. So what about dysplasia detection methods, right? So some of these are helpful, some of these maybe not, some maybe need more work. So, we've got traditional colonoscopy, and this was the Hershowitz scope. Basil Hershowitz was briefly at University of Michigan, but I understand he was a challenging man to work with before my time. But we've come a long way, right? So random biopsies we'll talk about. We're all basically in this room using high-definition colonoscopy. But then there's also the question of mucosal enhancement techniques to try to better detect difficult-to-see dysplasia. Chromoendoscopy, virtual chromoendoscopy, narrow band imaging, what do we do? So this is what colonoscopy looked like in the 1970s. And these were photographs from a sigmoidoscopy. And in the upper left, that's a pedunculated polyp that I can barely see. It might be an acecol capsule, I don't know. Acecol didn't really exist then, so. Normal sigmoidoscopies, I can make some things out. Bottom right is a carcinoma in the rectum. I can imagine if there was a bad bowel prep, quickly moving through that. But this, in the 70s and 80s, and to some degree the 90s, we were somewhat limited in our visualization technology. So there's a lot of interest of like, well, how can we do better? And a lot of work over decades on enhancement techniques like dye-based chromoendoscopy. Here's a panel of some images. Once they have been coated with, in this case, some of these are all, I think, indigo carmine, and they are used basically to enhance the appearance of mucosal irregularities. And there's also other technologies that try to avoid the messy dyes and instead use virtual chromoendoscopy or narrower bandwidths of light that help enhance vascularity. That's what most of those techniques are trying to do to detect dysplasia. So different technologies. My slides are auto-advancing again, so either you guys are speeding me up or thanks. I'm probably going too slow anyway. Scenic. For those of you not familiar with Scenic, Scenic was a group that was put together by the ASGE. I think Lauren Lane from Yale was leading this. And Scenic was looking at how can we do a better job with dysplasia detection. And they looked a lot at chromoendoscopy. And the point of these slides we're kind of looking at on the left, white light endoscopy versus chromoendoscopy and the different odds ratios. And on the right, you're looking at narrowband imaging versus chromoendoscopy. And in 2015, this study was a big deal for those of us that treat a lot of IBD because Scenic guidelines came out and said, well, they were more suggestions than guidelines, but they said they were recommending chromoendoscopy over white light alone, right? They were not recommending narrowband imaging at that time because the narrowband imaging didn't really show much superiority over chromo. And so they made a statement that chromoendoscopy with a dye should be really used in any high-risk patient. Kind of vague on what constituted high risk, but that kind of shook the field up a little bit because we're thinking, well, does every patient need chromo? Who needs chromo? What do you mean by high risk? Chromo's a mess. I hate doing it. It takes forever. I'm not sure what I'm looking at. So this was tough, but we're trying to find better ways to detect cancer. But as time went on, and multiple studies after 2015 were done to look at, well, what's the utility of this? We were starting to question the value of chromoendoscopy. So in a series of studies done in the United States and one in Europe, the meta-analysis has shown that actually if you compare traditional dye chromoendoscopy to high-definition white light endoscopy, which is essentially what we're all using, in all patients, they didn't really find a statistical difference in terms of the yield of dysplasia detection. Now this is not kind of looking at just high-risk patients that might benefit more from this or where you really have to find dysplasia, but they didn't see a difference in dysplasia yield. So it questioned the idea of do we have to do this for everybody? So where are we at now? Well, there have been two different statements made. So Scenic has kind of come back again and based on more study and more information has kind of revised some of their suggestions. And there's a great paper that Fernando Vallejos and Dr. Murthy wrote a couple years ago in Gastro, which was a clinical practice update. Both are shown here. And more or less they softened the recommendations for when and where and should you be using chromoendoscopy. Both of the statements said everyone should be using high-def endoscopy for all surveillance, but at least in the United States, there's very few groups who are not using high-def. They also both made a comment that if you're doing chromoendoscopy, you should have some kind of training. We're still trying to figure out what being trained or certified in chromoendoscopy is. And both, though, were saying that it should probably be relegated to high-risk patients, but you're free to use it in anybody. So I think what these two statements are saying is chromoendoscopy still has value. It still is probably going to help you detect some dysplasia, but it's not required in everybody. And a good exam is probably as important than just using the dye. What about random biopsies, right? I still use a lot of random biopsies, but there's been questions of, do these really help us, or are we just making ourselves feel better and spending time and money? So there's a couple reasons historically of why we've done random biopsies for dysplasia detection. Let me try to go backwards here. There we go. First, back in the 1990s and early 2000s, the SEER database, which is a cancer database, not a GI database, it's an international kind of set of cancer incidents, was reporting that compared to non-IBD patients, The interval risk of developing a new colorectal cancer after you've already had a colonoscopy is much, much higher in IBD patients compared to non-IBD patients. Now, there's a lot of reasons this may be possible. Maybe they had bad bowel preps in IBD because it's more difficult for them to do the prep. Maybe the active disease kind of hid possible dysplasia or other masses. But this kind of got the field worried that we're missing cancer that's there, so maybe we should do random biopsies, right? The second thing was this idea of hidden colorectal cancer, right? This information was back from the 1980s and 90s, and it was the observation that in patients who had high-grade dysplasia, but on biopsies no detection of cancer, 30 to 40% of them on colectomy were found to have cancer that was not detected at the time of colonoscopy. Also, somewhere between 10 and 20% of patients with low-grade dysplasia had cancer undetected on colonoscopy. This was, again, data from the 80s and 90s, but the idea was that there's hidden dysplasia present, there's hidden things we're not seeing, we should do random biopsies. And then the third issue was, again, this idea of synchronous visible lesions, and this is a study out of Mayo Clinic where they looked at 3,000 patients who underwent a colectomy, and they found that 16% of patients who underwent a colectomy had dysplasia on the surgical specimen that was never seen by colonoscopy and it was never captured by any other modality, right? Furthermore, 7% of patients that had known dysplasia or cancer had a second site that was undetected. So you put all this together, and it makes us think that we're not seeing things, and this is where random biopsies came from. That's the historical perspective. So a lot of us do this. I still do this, but less often now. Biopsy protocols, 4-quadrant biopsies. This is a slide from the 1991. And trying to sample tissue to detect that invisible or hard to see dysplasia. But again, as time has gone on, we're seeing reduced utility of these random biopsies, especially if you have a high quality colonoscopy, right? So this is a study recently that came out of the Jetaid group in Lille, France. This is their kind of international kind of cooperative of multiple gastroenterology sites within the entire country. And they looked at 1,000 UC patients, and they actually found 140 neoplastic or dysplastic sites in these patients at some point. And the majority of them were found on targeted biopsies, right? And random biopsies had very little yield. In fact, in 1,000 patients, only 12 patients had dysplasia found at random, and all 12 of them were low-grade dysplasia. And the 2 high-grade dysplasias that were seen on random biopsy were also picked up by targeted biopsy. So this Jetaid national study from many sites has suggested that maybe the yield of random biopsies isn't quite as high as we thought it was, right? In those patients that had detection of dysplasia on random but not on targeted biopsies, the risk factors that we've already talked about for colorectal cancer and IBD were seen in the majority of those patients. So now we've got these different recommendations from 2021 and 2022 on when to perform random biopsies and when to perform chromoendoscopy, and these are the references here, and you can look those up in your packets as well for more detail. But I'll tell you practically, putting all this together, my own practice, what I'm doing. First and foremost, I begin with a high quality examination. I scare the poop literally out of all my patients, right? That the prep is essential. A good bowel prep is absolutely essential, and I tell them if it's not prepped, I'm not going to see it. And so we spend a lot of time on preps and diet modifications for IBD patients to get the best look we can. And I slow down, and I take a long time on colonoscopy in my IBD patients for surveillance. That alone right there is going to cover most of the detection. I use the risk-based screening intervals that we shared already. I mainly do targeted biopsies now for suspicious regions, but I am doing chromoendoscopy plus random biopsies still in my very high-risk patients. So the PSC population, the family history, the pseudopolyp population, they're the ones that are getting chromo plus random biopsy. That high-risk group that's pretty small, I give them everything. It takes me an hour to do their colonoscopy. Managing dysplasia, I'm going to briefly go through this because you've got Dr. Rex here and you've got Dr. Praka and a lot of other people that are smarter at this than me, but here's the bottom line. The bottom line is that in the past, the detection of dysplasia, high grade and sometimes low grade, resulted in a colectomy for patients. That's no longer the case. We visualize the lesions better. Once lesions are found, we can do chromoendoscopy and verify that there's no other synchronous lesions as best as possible. And for the right types of lesions that are well demarcated, either endoscopic mucosal resection or submucosal dissection are increasingly successful for managing these without a colectomy for the right types of patients. So multiple studies, and I referenced them here, have shown that both EMR and ESD are safe and very effective for IBD-related dysplasia. In many times, doing EMRs and ESDs frequently upgrade the diagnosis, where low-grade dysplasia is upgraded in 3.5% of cases. When you find high-grade dysplasia and do an EMR or ESD, close to 18% of those cases, they're finding cancer in the deeper specimens, right? So when you find these, I won't speak for all of you, but for me and us, simple IBD folks, I actually don't do the EMRs and ESDs myself. I refer them to therapeutic endoscopy. But what I do is I biopsy, I tattoo very well, and then I consult them to let them know the details of the case to see if they're a good patient for this. But the idea is surgery is not mandatory for dysplasia anymore. Endoscopic techniques are there. We'll close with strictures. I like strictures because I feel like surgeons often get all the credit in my disease, and it's nice when I can make the patient feel better right away. So endoscopic balloon dilation is still really underused. I think we could do this a lot more in patients, and I'll show you that it's really effective. The 4 S's of stricture dilation: short, simple, straight, and symptomatic. This is where it works best. These are not absolutes. I've dilated multifocal strictures over 50 centimeters of small bowel. But your best outcomes are for this kind of patient. The short stricture. Simple means there's no abscess or fistula. Straight means it's not highly angulated because it's hard to get the balloon across. And symptomatic is because there's a big debate on, is there benefit for prophylactic dilation? The patient with a stricture, but they say, I'm feeling fine, I'm not having obstructive symptoms. That's still debated. Personally, I do not dilate those patients, but potentially in time we may find that prophylactic dilation potentially could avoid future obstruction. I'm not going to do that study. The purpose of this slide is just to show that when you do balloon dilation, size matters, as is true in many things. The bigger you dilate, the longer that you go without having a repeat dilation or a surgery. This is a Kaplan-Meier curve that, typical of my own personal work, is overly complicated. The point is just that the bigger the dilation, the better the patients do. If you don't get the patient to a dilation of 18 to 20 millimeters, they're probably going to have recurrent endoscopies or eventually go to surgery. So if at all possible, you want to get to 18 to 20 millimeters. Is it durable and is it safe? Yes and yes. This is a combination of data from 2 different studies, one of them most recently from Dominic Bentonworth in Germany. What you're looking at is how long do these dilations last for, right? So the different colors, yellow means the patient had 1 dilation, orange means 2 to 4, green means more than 4 dilations, blue means didn't work, they had to go to surgery. All of this is retrospective data. The point is, in patients that have serial dilations over 5 years, 60% of them avoided surgery over 5 years, and 40% of patients who had just a single dilation were able to go 5 years having no problems, no hospitalizations, and no surgery, which is great. The location of the stricture doesn't matter. If it's a low colonic stricture, if it's a small bowel stricture, if it's anastomotic versus de novo stricture, doesn't seem to impact the success rate. Now, as far as complications, we generally quote a rate of like 2%. And the data, and this is from Dominic Bentonworth study, says 2.8%. I think that's biased towards European approaches. Interestingly, most of continental Europe is very aggressive with dilation. You come in, they find a stricture, they're just going to stretch it out to 18, 20 millimeters. No stage dilation, they don't stop, they just blow that thing open. And I think they have higher complications as a result of it. Most of that, I think, is because of access issues with colonoscopy in Germany and in Italy. And these are the typical complications: pain, bleeding, perforation. So I counsel patients on upwards of a 2% risk of perforation. But I think stage dilation, kind of dilate it until you get a lot of resistance or heavy bleeding, that's when we stop, bring them back. I'm often bringing patients back maybe 2 or 3 times to get them to 18 to 20 millimeters and then touch them up every couple years. Can we do more than balloons? Yes. The evolving field of endoscopic stricturotomy is coming, and it's making a lot of progress. If you have a classic stricture and you're considering surgery, endoscopic stricturotomies have recently been shown, and this is a paper from GIE from a few years ago, to be as effective in terms of the need for repeat surgery, the complication rate, and patient symptomatic response. They've been as effective as a classic ileocolic resection, and this is all in ileocecal strictures. They found no difference in surgery-free survival, and their data went to upwards of 8 years. And interestingly, the endoscopic stricturotomy actually had less adverse events than a classic surgery. So this requires a lot of training, a lot of knowledge. I don't know that this experience is out there everywhere, but I think there's pockets of experience that are growing, and we're going to start integrating more in IBD with our therapeutic endoscopists to help us with this. Stents. I want stents to work so bad, but they just so rarely do. This was a study of self-expanding metal stents versus balloon dilation. And more or less it doesn't work. We keep trying stents in IBD to kind of open these strictures up, but we just really haven't found a lot of routine success in this. These studies are all pretty small. This is the best one that I know of, 80 patients, and they were randomized to either stenting or balloon dilation. The balloon dilation was more effective. Patients had less symptoms and had less return visits to the hospital afterwards. So there's probably going to be a future for stenting, but we need more work from the engineers in terms of material science and drug-eluting stents and absorbable materials before we can do this routinely. I don't think that it's totally out of line to do stents in very specific patients, but we rarely do them. So that's a tour de force, right? And hopefully covered a lot of ground. The key points, just as we close, the cancer risk in IBD is reduced. We've been doing a great job because we're surveilling patients and we're treating their IBD better, but the risk still remains elevated. Risk stratify patients for judicious use of surveillance colonoscopy. If they're in remission and they never had a problem, you can go every 5 years, but for those patients that are high risk, they have to have it a colonoscopy every year. Chromoendoscopy and random biopsy are most helpful in the highest risk patients. Endoscopic resection of dysplasia is possible. And we talked about balloon dilation as a great alternative to surgery. Thanks.
Thank you, Ryan, and I'd like to just extend my appreciation to the course organizers and the event planners for today. I think this has been a lovely event. This is my first time at this as a GI Society event, but I'll share that in my other roles as mother and wife of a cardiologist. I'm here for Michigan ACC roughly every fall, and it's always bugged me. I'm at the pool with the kids, and I'm like, what the heck, GI? Where are we? Why aren't we doing this? So Jamie and Rick must have heard me musing from Ann Arbor, so I really appreciate that you've revived this. It's great to be here. All right, so hopefully I can get this going. Green. Okay. Well, I appreciate the kind introduction earlier, Jamie, and this afternoon I'll be sharing with everybody another tour de force, particularly with regards to therapy and IBD. I do work with pharmaceutical industry to an extent. Okay, so overall timeline here on how it's gone for IBD therapy in the last roughly 20 years. I have a distinct recollection of being a medical student in pharmacology class, and thank heavens this professor put up a slide about this novel therapeutic called TNF-alpha, and he had just covered 4 minutes of sulfasalazine, azathioprine, and prednisone for inflammatory bowel disease. And at this point, I'm, I think, a first year medical student, maybe second year. I already knew I was doing GI because I'm a foodie and I'm a chef, so that part was easy, and I sort of wanted to do surgical things, but not really, so GI was it for me. And then this professor put up a slide on this novel concept of blocking a singular cytokine. And it was I just thought it was the coolest thing in the world. And lo and behold, here we are. So that was infliximab that professor shared many years ago. And again, throughout training, Dr. Ryan Stidham and I were co-fellows, and it was this super cool thing to try this TNF alpha, and that's all we had in those days. And biologics were, when we said biologics, we meant TNF, and that was it. And then it wasn't until 2014 that we got the next biologic. And once again, I recall Jason Shire and I in clinic, and we just thought it was the neatest thing on the planet. We have a new mechanism. And now as you look at this bar on the right side of your screen, within that red bar are 3 different classes, 3 different mechanisms of action of different avenues by which we can block cytokines and block monoclonal antibodies from wreaking havoc in the GI tract. And at the risk of sounding trite, we are kind of building the plane while we fly it, because as each of these therapies comes out, we learn more about the adverse events from that level of cytokine blockade. And it's been a fascinating decade or so in this field, but the whole and the continued theme that I'll return to as I show you, again, some charts and graphs that might be overly complicated, like Dr. Stidham shared. The whole here is that we don't exactly have great data on which therapy to use in which patients. So that's kind of the overall crux. There are about, I'd say, over 100 such complicated diagrams. Anyone can find them when you just start PubMeding enough, and identifying various different mechanisms by which the people try to make sense of the immune system. And I find every time I look at one of these, I start to get a better sense of the way that T helper cells interact and lead to different cytokine blockades, but I always find that there's a little difference in each of them. And what I take from this various iterations of immunotherapy, what I take from it is that we don't totally understand every little detail. Each of these diagrams is a gross oversimplification of what actually goes on. But what I share with you on this chart here is the various mechanisms at which we can block cytokines so that patients can have a decreased immune response. Of course, you see the TNFs at the middle of the screen. Up top, you have the ustekinumab and brykinumab to block interleukin 12 and 23. And then specific to interleukin 12 and 23 blockade, you see it on the upper right corner. I'll go into a brief amount of depth on each of these therapies, and can also share some of the ways in which the outcome data have evolved as well. Okay. So interleukin 12 and 23. What we're talking about here is ustekinumab, trade name Stelara, as well as risankizumab, recently FDA approved as Skyrizi, guselkumab, and mirikizumab. Mirikizumab at this point is closer to FDA approval, but we're all excited to see that one in the not too distant future. What we found over the years is that a common subunit, P40, is common to both interleukin 12 and interleukin 23. But we've also identified that interleukin 23 seems to be a bit more responsible for Crohn's disease and ulcerative colitis, and therefore that target has been specifically targeted by utilizing the P19 subunit. Overall, ustekinumab is a reasonable therapy to think about when your patient has concomitant dermatologic conditions. I like to keep up with rheumatologic and dermatologic literature because I find that it's kind of a sneak preview for IBD. If you can see what's going on in rheum and derm, you kind of have an idea of what's coming for Crohn's and ulcerative colitis. Okay, so in these complicated graphs and charts that I'm going to show you, the punchline overall is that these therapies work in about half of patients, about half. That's about it. So here we have the phase 3 data on clinical response for ustekinumab, and in this situation, we are using the change in Crohn's disease activity index. There's two subgroups on the side, Unity 1 and Unity 2. The Unity 1 patients are bio-experienced, meaning they've been exposed to previous TNF-alpha therapy. Because the study was done in 2011, the only previous bio-experience was TNF. And Unity 2, these patients are bio-naive, so not yet exposed to the therapy. And you can see the population of bio-naive patients plays a big role in whether or not a patient will respond. I've always found that fascinating. Why is that the case? Did we already burn out part of their inflammatory response by treating them with TNF-alpha? Kind of a simplistic way to think about it, but we see this consistently in every therapy we look at. And the initial biologic that's used for any patient is always the most powerful one. Yet none of these therapies reach success rates of 80-90%. What I take from that is that there's probably a multitude of cytokines involved in every patient's IBD. Can we profile that? No. I hope we get there one day. We're not there today. Okay. Reasonably quick-acting drug here with ustekinumab, weeks 6 or 8. Pretty good. Risankizumab, which, oops, could we go back one? I didn't mean to click forward so quickly. Okay. So one of the key points I wanted to show you on this chart with all of these graphs is that we evolved quite a bit between 2011 and 2022 with regards to what types of outcome measures we look at. Of course, the Crohn's Disease Activity Index is always our go-to for measuring clinical response to Crohn's disease patients. But we also added fecal calprotectin. We added endoscopic response. That became kind of the norm as the years passed. And so we added a degree of sophistication to the outcomes. We even started adding CRP in some of these studies as well. And once again, we find that about half of patients respond. No matter how you slice the numbers, that's usually the conclusion you can come to. Again, further outcome measures here looking at fecal calprotectin, change in high sensitivity CRP. Okay, I know I'm going quite rapidly in this tour de force, but I think I just wanted to give a high-level overview. JAK inhibition, relatively newer relative to TNF and interleukin-23. JAK inhibition, specifically with tofacitinib and upadacitinib, lovely, rapid way to calm down both ulcerative colitis and Crohn's disease, depending on the drug we're talking about specifically. But this drug can take effect within 2 weeks. It's one of the most beautiful things to see when a patient can actually literally be spared steroids. New onset IBD, start the JAK, some see response within 3 days. I've had several patients, this is when the JAKs first came out, clearly need a colectomy, finally agree to meet the surgeon. And this in the first few months, and it was when the TOFA was first approved in 2017. You know, Mr. So-and-so, you can try this new therapy. There are data to show that it does work quickly. You could try it, but I really need you to meet this surgeon because you're in a rough spot. And I've had a few of such patients in this scenario do so well, so quickly, they never met the surgeon, they never needed to meet the surgeon, and they're now fine. And these are individuals who have failed multiple biologics. So the JAKs can get you out of a rough spot. That being said, I'll circle back to the same point, we don't have predictive data for in whom this will work. We just trial and error. So on the one hand, it's lovely to have so many therapeutic options. On the other hand, we're missing a key piece of data. And fellows, trainees, I'm excited that so many of you are here, but for those of you interested in research, that's what we need to fix, predictive analytics. That's the answer. Okay. Tofacitinib, just a little more data to show the mucosal healing, or I should say mucosal improvement with this therapy. About half of patients at 1 year experience 45% rate of mucosal improvement. Upadacitinib, lots of outcomes data here. Again, like I mentioned, we're getting more sophisticated. Fecal calprotectin, CRP, clinical response, and clinical remission, of course, and mucosal improvement. And yet again, about half of patients improve. Again, rapid time to onset, JAK inhibition, roughly 2 weeks, and patients can be doing okay. Okay, I'll skip over dosage since I know I'm going to leave some time for Dr. Stidham. Ozanimod, FDA approved for ulcerative colitis, a lovely choice for therapy for patients who particularly choose oral therapy, also can be rapid in onset as well. Got to be careful in the setting of pregnancy, cardiac arrhythmias, and macular degeneration. Kind of random things to keep track of, but after a while it becomes old hat. Hopefully we'll have this one around for Crohn's disease in the not too distant future as well. Okay. Mirikizumab, not yet FDA approved. Roughly half of patients are responding in the phase 2 data I'm showing you here. And now, ultimately, like I said earlier, we are learning as we go. We have our dendritic cells, the cytokines, the intended therapeutic targets, and then we learn from those targets exactly how these therapies function and what negative effects that they have. We learned that in that manner. IL-17, I just want to share with this group that we have negative data here. And the reason I bring this up is because I think this highlights how poorly understood these processes are. These are not linear pathways. They are upside down, sideways, circular, all over the place. But IL-17, it's one of the questions on your CME evaluation, by the way. IL-17 is not a therapeutic target for Crohn's disease. It actually causes a pro-inflammatory problem in the setting of inflammatory bowel disease. So I think the fact that this one was a negative study highlights that we don't totally get how the cytokine cascades actually work. So ultimately, we have a large armamentarium today for the treatment of inflammatory bowel disease. It's challenging to select a therapeutic target. We have a little bit of guidance, such as skin conditions, think ustekinumab. Need rapid onset, think about the JAKs. Beyond some minor guidance, like those clinical factors, we don't have profound, distinct analytics on how to guide which therapy should be used in whom. So I semi-joke about it that I feel like a Vegas card dealer sometimes in a moderately severe IBD, because I'll ask patients, what are you feeling? Would you prefer an IV or would you prefer a pill? And sometimes they kind of appreciate having that level of input, but sometimes my more educated or savvy patients, they kind of look at me like, you're the doctor. Why don't you know which one to give me? And I semi-joke about this because it's partially rooted in a level of sadness that we don't know. We have a little bit of comparative data, but not quite enough. So I'll end by hopefully invigorating some motivation in our trainees. That's what we need to improve upon. So get to it, folks. Thanks so much for the attention.
All right, Dr. Stidham, you're going to take us through the last part of some just updates in IBD and with some data from DDW. And then we'll open it up to questions. So if you have any questions, please make sure you've written them down. I've got a couple to start us off with when Dr. Stidham is done.
Hi again. Thanks, Nirmal. And thanks again, Jamie. Part 2, kind of what was going on in DDW this year. It's kind of like a circus there. And my hope is to talk about sensors and surgery, a little bit different, right? Dr. Kaur just told you everything you need to know about modern medication armamentarium. I'm interested in these topics because I think that, maybe they don't get enough attention, and some of these very early technologies I think are going to end up in our practice pretty soon. So at the very least, they're interesting. my disclosures. Sensors, just a couple here. First, we'll talk about ultrasound. I studied ultrasound as a fellow, and then for many years afterwards, I couldn't really make it work in IBD. Like, we could write some papers and things, but my team couldn't really make it clinically useful. But other people are, because it would be such a great modality, because ultrasound can be point of care, it's radiation free, it's like cheap, it's easy, you get to show the patient pictures, it's fun. But other groups are moving this forward and I think making it more practical. So we've seen a lot of work with intestinal ultrasound, and some of the, this is not comprehensive, but some of the interesting things from DDW that you might have missed was that ultrasound can also be used to approximate endoscopic activity in ulcerative colitis. And this was a group from Italy who's very well credentialed and experienced in ultrasound evaluation. But beyond just saying that you can use point of care ultrasound to assess ulcerative colitis activity in the colon with ultrasound, they were showing that you could do it with a handheld, off-the-shelf, gastroenterologist-directed ultrasound machine. And there's more and more of these available. Like you can, like Butterfly is a company where, you know, maybe you can get your institution to buy you like a couple for, you know, you or your fellows, and they're like $1,000 a piece, and just run around scanning people. You know, I don't really know what we're looking at, but the Italian group says there's things there and they can be useful. So the takeaway from their data is that they were able to show that they could distinguish active from inactive ulcerative colitis by scanning the colon with an ultrasound, and whether it was a Mayo 2 or 3 or a 0 or 1 in multiple sections of the colon. And they found that those scores with the handheld were no different than if they were to do a traditional radiologist-directed ultrasound. And this was using like really, really simple features. Takeaway is ultrasound is probably coming for IBD, both Crohn's and ulcerative colitis. And slowly, groups are starting to make the investment in not just the equipment, but the training on how to use it. And it's anticipated that this is probably going to be integrated into just part of our routine clinical examination. Like, why do a, you know, just mash around in their belly when you can do an ultrasound and take a look? So this will be coming. Some other ultrasound work is from Mike Dollinger, who's at Sinai. He's a young guy there, but making a career on studying ultrasound. And they did more work in Crohn's disease, which has been where there's more of a history of ultrasound, principally in pediatric, but also in adult patients. And more or less their work was actually a validation study, showing that they were taking multiple different ultrasound parameters of the small bowel, and they were able to correlate them with endoscopic remission, or an SCS-CD score of less than 2. So this group, which Mike told me should be published pretty soon, was showing that they can use an ultrasound if you know what you're looking for to tell you if the patient's in remission or not. So point of care right in the office, that's pretty cool. Other sensors. Over half of my time now is in engineering. I have an appointment in engineering at Michigan, and so we do a lot of hardware and software development to stay entertained. But this is from Dr. Prasad, who's in Texas, I think UT Southwestern, looking at sweat analysis for using IBD biomarkers. This is super cool, right? So, you know, we've got all these different biomarkers, blood-based biomarkers like CRP, stool biomarkers like calprotectin. Of course, we can do a CTE or a endoscopy. But her group has actually been developing sweat-based sensors. In this lower corner of her graphic, this is like a wristwatch device the patients would wear for approximately an hour, and it would detect trace amounts of CRP, IL-6, and calprotectin from the blood into sweat at microscopic amounts, actually picograms. And then there's some cloud analysis that's done to kind of correlate this. And they introduced this work now in a very small set. This was a pilot study. It was kind of open label, not blinded. University of Chicago was kind of the clinical partner there. They took about 30 patients with UC and Crohn's, as shown here. Some were active, some were inactive. And they have a long way to go, but that's okay because this is research and it takes some time. But they've already started a company for this. It's actually being funded by in part by the Crohn's and Colitis Foundation's venture arm. And these graphs are basically showing the correlation from CRP in serum, IL-6 in serum, and calprotectin. and the correlation of that with this sweat sensor. And these R values are the Pearson correlation coefficient. 1 is perfect, 0 is nothing. And you can see the scatter plot, it's not perfect, but in principle it's there. So the future that we're imagining is that the patient, just like, maybe one of your smart watches, for those of you that wear them, I don't because I'm paranoid of being surveilled by the man. Rest in peace, Steve Jobs. But the idea is you'll be able to continuously monitor patients' activity. I don't know what the hell we're going to do with all this data, but the idea is that you can collect it in real time, which is really exciting. And I like new stuff, like we're moving forward. It didn't really work, this IL-6 detection, for kind of distinguishing remission or not. What you're seeing on the left panel is the bar graphs for active patients versus remission patients in like the sweat levels of IL-6. When they measured IL-6 in the serum, it did split patients, so it tells us like this isn't quite ready yet. But I think that the principle is there, the technology is there, and they're going to make it work. Very brief, just one headliner, because I think it's important, was about upadacitinib and fistulas for Crohn's disease, particularly perianal fistulas. This is so hard. Like, we see these patients and we try our best, like throwing medicines at them, and we hope it works. And there's usually a lot of surgery and sadness. But upadacitinib is actually really showing a lot of great promise as a JAK inhibitor for helping with fistulas. You have access to all these slide decks. The point is, UPA works in perianal fistulizing disease. It really works, so feel free to use it. Those were the sensors. Here's the surgeries. There's been some interesting surgical stuff this year at the DDW. Is surgical resection at diagnosis equal or better than anti-TNF? You meet the patient, they've got some small bowel disease. We could give them medicine, and maybe that'll work, or we could just whack it out. I was trained, given medicine, avoid surgery, but maybe there's other ways to do this. So this is part of a collaboration between Mount Sinai and actually Tina Jess again in Copenhagen, and this PREDICT group. So just like a big consortium, but they actually did a study where they were looking at patients where they prospectively would have them do a ileoclonic resection at diagnosis, or they got an anti-TNF. They matched these patients, and essentially what this graph is showing is the red line are patients that had surgery, the blue line are patients that had anti-TNF, and the y-axis represents bad outcomes for the patient, being repeat surgery, steroid use, hospitalization for IBD. And actually, over a 15-year period, the ileoclonic resection group did overall better. So that may make us rethink our idea. Right now a lot of us are focused on sequencing of drugs. I've got 10 drugs available. Which do I use first, second? When do I combine? I don't know. Well, we might have to add surgery into the mix where maybe we just operate right away and watch them and hope for the best. None of these patients, by the way, that had surgery went on medicine afterwards. Interesting. When they did the risk factor analysis, just for those of you out there that are detail specific, they actually found that even controlling for all the different risk factors about the patients, that the ileoclonic resection was better. And then what about the type of surgery that we do? When you have to have a surgery, there's end-to-side anastomosis, end-to-end anastomosis. A lot of it's based on, what the patient can handle and the surgeon's, opinion. But what about rethinking the types of anastomosis? So there's one called the Kono-S, which was developed in Japan in the 90s. It didn't really take off because, like everything from Japan, it's much more complicated and takes much, much longer. But it may be better. They're showing results from an Italian study using the Kono-S procedure where there was less postoperative Crohn's disease recurrence when you used a different kind of anastomosis. This is what the Kono-S looks like. The principles of the Kono-S are that it's just bigger. The lumen that it creates is larger. And the concept or premise of that is there's less fecal stasis perhaps lower microbial concentration, and maybe, perhaps in part, this is part of the reason for developing complications at the anastomosis. In addition, because it's wider and there's a higher flow state there, you might not have those pressure gradients, and we know that when the small bowel gets pressurized, this enhances fibrosis. So that was the theoretical principle behind it. But to cut to the chase here, what they found are when patients got the Cone-OS versus a traditional endoside anastomosis, everything was better for that patient over 3 years, including significantly less endoscopic recurrence, which is the big figure that you see on the left. The Cone-OS patients, only 33% of them had a Rooker's score or recurrence of disease at the anastomosis. That was significant, compared to conventional anastomosis, where it was 75%. And then, other kind of components were favorable as well. In addition, when they looked at this cono anastomosis versus conventional anastomosis, this was like the strongest factor in the multivariate modeling of why the patient did better. They controlled for, post-operative biologics, they controlled for the use of immunomodulators, they controlled for smoking, and the only two factors that mattered were the type of anastomosis they did and the extent of disease, like how bad was the Crohn's, how much was involved. And the type of anastomosis was the major factor here. This is a big change to practice, and maybe this is what we should be doing. Our surgeons don't do this at the University of Michigan, but maybe they should start. So that was kind of just briefly some of the interesting things that DDW might have missed. And thanks again, and I guess Dr. Knukin will lead our question panel. So thank you.
Thank you. I'm loud. I'll take any questions. I'll start off as you are all thinking or walking up. Please raise your hand. We do have some portable mics, and we have some microphones that are now moving from their stationary position. One of the things that I've seen in my practice, as you talked about, kind of how do we do away with random biopsies, is I've started to see, and we've published from Mayo Clinic on it, and we actually have a new series that we're going to be publishing soon, is looking at those changes that the pathologists call superficial hyperplastic change, or serrated epithelial change, which, at least in some of the studies that have been published so far, are either invisible or in some cases can be visible. In the audience, for those of you that are in practice taking random biopsies, how many of you have seen this pathologic change and kind of not known what to do with it? Nobody, just me. So is this something that you guys are seeing in your institutions?
Honestly, this is the first time hearing of this pathology. No, and we've shifted to what Ryan described, high definition white light versus chromo. But I was talking to one of the course leaders earlier today. The tech started making fun of me because they started with, Dr. Kaur, you always say you're going to do chromo, and then you never do because the preps just stink. And so the prep really has to be perfect if you're going to pull off a chromo. So I often will say, this is a likely chromo, let's give it a shot, and then I'm in sigmoid or descending, I'm like, it's not happening, there's too much yellow, and then I'll shift to high definition white light with just a careful look. And then what I do, Jamie, and I'm curious to hear what Ryan has to say, is I shift to NBI when anything looks even remotely odd, and if I even have to take more than a half second there, I'll biopsy it. But I'm not doing the routine randoms anymore, and that's kind of what we've shifted to. Curious to hear your practice, Ryan.
I don't really have a lot to add to everything Dr. Kaur just said, and to Jamie's point of what do we do with these pathologic changes, I don't really know. I don't know how that influences this. I don't know if this is something that we should be paying attention to or not. We probably should. But there's just an information gap there. So
yeah, that's why we're looking at it. So the studies, I was just looking it up on a previous talk I gave. So the studies that, this is Alyssa Perrin out of Johns Hopkins who did it in conjunction with David Rubin, and they showed that the prevalence was 2 to 3%. So it's not zero. And then it shows that there can be both synchronous and then asynchronous, meaning future endoscopy showing dysplasia that's actually quite high. I think the percentages were up to 21% dysplasia in the future and 3% colon cancer. So I think it's something to have on your radar. That's why I haven't done away completely with random biopsies. And then a quick question, snap answer, dye or virtual chromoendoscopy?
Virtual.
Virtual.
And so I'm virtual too, so I've really gotten away from doing pan-colonic dye spray and really targeting those atypical lesions with more targeted dye spray, which is a different concentration if you read the original scenic consensus statement, which is a more targeted darker stain, but that's where I'm using that. And in addition, and I don't get paid from the company, we recently trialed the Fuji scopes. Yeah. And they have a really cool technology on the Fuji, one of the Fuji scopes, that it can zoom in on what you're seeing endoscopically. That is, you can tell it was a tubulovillous adenoma just by zooming in on it. And so I think we're going to even get more enhanced endoscopic abilities in the near future. So just a word on those things. But Megan has, we have somebody with a question over there.
So this is Hussein Hagbin from a Session Providence Fellow. So just a comment regarding that study by Dr. Agrawal that was a comparison between surgery to anti-TNF. So as I recall, it had multiple limitations. Number one, it was administrative data, and number two, as Dr. Higgins also mentioned in DDW, is that they did not see the amount of exposure to anti-TNF. So surgery is a one-time thing, and it's like 100% exposure. But anti-TNF, maybe some people don't take it, some people take it. You know, in the middle of it, there is interruption. So all of these are limitations of the study.
Yeah, I completely agree. I think the takeaway from the study is that the possibility is there, right? That there are patients where an operation can be, curative is the wrong word, but it can be a durable solution, that with the right amount of monitoring, those patients exist. And I agree with you where the gap is, and Dr. Kaur was talking about this, is figuring out which patients are which, right? Like how do we profile or phenotype the best kind of patient for this? Because it's very hard in real world to kind of control for all of those factors. And then you have to do some kind of like randomized controlled study, and then you got to find the money to do it, and then that's never going to happen, so we would never know. So hopefully these studies influence stakeholders to say, you know what, we should do those studies. And maybe it's CMS, maybe it's pharmaceutical industry. I don't know, but your point's well taken and absolutely correct. But the promise is there and the potential is there for some patients to do very well with surgery.
And I'm going to tag you because it sounds like, I mean, one of the themes was, and the most common question I feel like that comes from providers who aren't fortunate enough to just see one disease state like we are, is, okay, you've now got this toolbox that's overflowing with options. How do you pick? And so what resources can we give our audience in terms of guiding them as to, how do you position therapies? What are you kind of using in your practice? In a bio-naive patient, I think is probably that common example where you have the world is your oyster. You can pick a ton of things outside of a JAK inhibitor.
Well, there's a few ways you can go about it. In the very severe patient, so this individual's been hospitalized, hemoglobin might be less than 10, they might need some IV iron or a blood transfusion. In those situations, the data are not always equivalent across classes, and in those situations, I think about CySIF, so this is cyclosporin versus infliximab data, and I kind of keep that for the severe UC. But if we're truly just in the world of moderate, that's a tough spot to be in, and that's what I was citing earlier. I'll often turn to the patient. I can offer you a lot of different things, and I literally take out a blank sheet of paper and I make a big chart. Route of administration, mechanism of action, side effect profile, and rough rate of effectiveness. Now, the rate of effectiveness, one could argue, I always say this is a gestalt and a combination of studies, and I give that piece of paper to my patient, and I just say, here's where we are. And some patients really appreciate that level of detail and having those options, but some patients, what the heck, doc? Tell me which one to do. What would you do? I'm like, it's a rough problem to complain about, but you've got a lot of options. So I go back to concomitant skin issues, lean towards ustekinumab. Let's talk about pregnancy, young women. Are you considering that? Because not all of these therapies are safe there. So you can tease apart some of those clinical factors, but then it ends up becoming a shared decision-making model.
And then you have to find an insurance company that agrees with that
Yes.
very thoughtful discussion you
And you're
had.
going to fix that in the morning, right?
And speaking of that, yeah, tomorrow morning, 7 a.m., coffee and coding. But winning the prior authorization game, I'm thinking I'm going to spend a little bit less time on. But if you want to figure out how you might be losing money or leaving money at the table and not get reimbursement, wake up. You can have your coffee. If you want to put stuff in it, I won't judge you.
What happened to cocktails and coding?
Well, cocktails and coding can't happen at 7 a.m. I was told that was not allowed.
Bad look, okay.
So again, no judgments if you put something in your coffee, but come and join us at 7 a.m. for that. But I think that you're raising a really important point, which is shared decision making. I think we have a question from our original founder, Dr. Saad.
Yeah, question for Ryan, and probably for all of you. So how much does inflammation matter for these stricture dilations?
Oh, that's a good question.
The data says it doesn't matter. So Dominic's study says it doesn't matter. My study says it doesn't matter. But, to the point earlier, just because you have a study and a reference and a p-value doesn't mean that we understand everything. So I still hesitate in my practice because the biology of that inflammation suggests to me that this seems like a bad idea. So let me give you something concrete. If I see some aphthous ulceration or some erythema, and it's a pretty tight stricture, and that patient has been imaged, and I know that on CTE or MRE there's no penetration, that patient I will still dilate. Because there's no such thing as a cold stricture. Like, inflammation always comes with every single stricture, and inflammation and fibrosis are intermixed. So you never get pure inflammation or pure fibrosis. But in the patient where there's, say, the Crohn's patient with deep cavitating ulcerations, I'm not going to dilate
You
them,
close your eyes and you
despite
do that
my
one?
own data. So yeah, I send them to someone
More cavalier than
foolish, smarter, or braver. I'm not sure which. Yeah.
Yeah, no, when I see a deep ulcer, even if it met all of your other criteria.
And do surgery. Do like a Cone OS. Do a surgery.
Endoscopic surgery. Yeah, endoscopic surgery. I do want to touch back on, you mentioned infliximab and cyclo. I want to point out how proud we are as a state that at the University of Michigan we did a study looking at tofacitinib in the inpatient setting in patients with acute severe ulcerative colitis, and know that that is commonly spoken on a national stage, and so that's our very own Jeff Berenstein in the state of Michigan. So we've got some great stuff that has come out of this state, and so I'm very proud of that. Not because I was on the study, but just because it's our state.
I think it's a big deal. It's a big deal. There was just other point I wanted to make on dysplasia, so I'm going backwards. And this is like a personal confession amongst friends and colleagues. We all do the same thing about this random biopsy thing. There were so many times where the prep was okay, or the insufflation wasn't great, and I'm just doing random biopsies to kind of give myself reassurance that I've checked this patient. They've had their random biopsies, I've done the colonoscopy, I've done my due diligence, it's cool. This is part of the reason why I'm advocating against thoughtful use of random biopsy, because just rolling through there and getting tissue and biopsies, if you're not looking, the data is clearly saying that the targeted biopsies are better because random biopsies are still only capturing about 5% of the surface area of the colon. So you still have to see it. Don't use random biopsy as a surrogate, as I've done a complete endoscopy. And that's a personal confession of mine where I would find myself doing that. And just because you took 40 biopsies, Ryan, doesn't really mean anything.
And I think what you spoke to is, what is the best prep in these patients, right? So you can't see polyps, you can't see dysplasia unless you can actually see the colon. And there's only been a few studies, but the one study I saw was split-based PEG as best in IBD patients for preparation. Have you guys been using that in your practice?
That's what we use. I don't have a great reason as to why my patients aren't always that clean. I think they think of me as a loosey-goosey, comfortable mom who will let them get away with stuff.
I'm a dictator when it comes to that because I know that I've missed things before and I found it. And we do a lot of dietary modification, especially in the Crohn's population, which is really onerous on us. It's onerous on my team. But it's what we have to get them through. Because if you've got a stricture or you've got a lot of symptoms, it's just so hard to drink the prep, and patients are doing their best. So a lot of diet modification days prior on top of split prep that Dr. Kanukin was referencing.
Some cool stuff that we're doing right now, and this will, Ryan will love this, is that we've built a model at Mayo Clinic to predict which patients, using their EHR data, will have a poor prep. So poor preparation is about 10 to 15% of our patients, and think about the utilization of resources when you have to reschedule that patient, or you do a colon and it's a meh, like, you don't really feel that confident that you saw everything. So we're working on that, and we hope to validate that in a general population, but then I'd love to partner so we can validate that in an IBD population. Because, right, you want to get it done the first time, and certainly we'll never have anybody show up for prep if we prep everybody with a 6 or an 8 liter extended preparation for their original colonoscopy, when we only need it in about 10 to 15% of people. So more to come on that. Anybody else with questions? We've got some experts up here. All right, go for it. I'll repeat it if you don't.
You do a surveillance on one of your IBD patients, you remove a traditional adenoma. Adenomas, by definition, they're low-grade dysplasia. So are you treating that now as a low, no? Or what's your interval? You do 2 years? You do 3 years? You do 1 year?
I've shifted to the Murthy data that Ryan just shared, and I think David Rubin put it best a couple years ago at AIBD. You're still allowed to get polyps if you have IBD. You're still allowed to get garden variety regular polyps like a regular person if you have IBD, and that's okay. So we used to call it polypoid dysplasia. We used to call it DALMS, right? Dysplasia associated lesion or mass. But now the phrasing is polypoid dysplasia versus flat dysplasia. So basically, Rick, you just described polypoid dysplasia, right? Because if there's an actual polyp, comes back as adenomatous tissue, yes, it's technically low-grade polypoid dysplasia in an IBD patient, but I would give them 2 to 3 years if it's less than 2 centimeters. Okay to stretch that out. We don't have to be as nervous as we were with scenic, which is just at this point only 8 years old. But that Murthy guideline, the fellows know, I literally Google image Murthy guideline, Rigero postoperative Crohn's algorithm, and that's how I teach the fellows, just with those images. So Google Image is a great tool. I don't know if you want to do anything differently or add anything.
No, and I think the challenge is that the pathologists confuse you, right? Because then the pathologist just doesn't call it an adenoma because they see the word IBD, they now say the word dysplasia. I think we got into it with Dr. Appelman at University of Michigan. He's now retired, but said, then stop saying dysplasia, just call it an adenoma so it doesn't confuse, the picture. But when it's in a polypoid structure like that, I treat it as a general standard adenoma.
Well, excellent talks, thank you. My question is way more basic than everything has been discussed so far. In Dr. Stidham's slides about the risk factors for dysplasia, there is like good factors and bad factors. On the good side was mesalamine or 5-ASAs and thiopurines, but no biologics. I don't know if it's a factor of how old the study is or the studies were based on that meta-analysis or not. And the reason I'm asking that question is that for years we've been taught that when you have ulcerative colitis, you move on to, patient progresses to biologics, you stop there, mesalamine, because there's no additional benefit. But then is this protection from dysplasia from mesalamine a factor of mesalamine itself, or is it a factor of decreasing the inflammation, in which case the biologics are providing that protection?
Can't be conclusive. The biologic problem was studied because this was recent, but they had difficulty separating the use of biologics with its association with severe disease, right? So, in larger populations, you skew much more towards moderate to severe disease. So in a fair statistical analysis, it's difficult to show that difference, even when you try to, in the modeling, in like a multivariate model, separate out like the disease severity from the drug use. So in this chemoprevention question of mesalamine, is this a natively chemoprotective agent, or alternatively, is this just disease control? We don't know that, and that's an answer we don't have a question to. And when I'm working with a patient, it often comes up in the UC patient who's in deep remission, been on 5-ASAs. Hey, do I need to still take this? And I just tell them, I don't know. There's some data that suggests that maybe this is protective against colon cancer, even in the absence of inflammation. Most of the decision-making comes down to the patient's desire to have this more or less medication insurance policy, as it will, to protect against the dysplasia that hopefully they will never have. It remains an unknown in this space. And while unsatisfying, that's the most honest answer I can give you.
I think the one thing that is clear from the data is that when a patient is able to achieve remission on, let's say, a more effective therapy, I hate saying the word advanced therapy, but the more effective therapy than mesalamine, is there value in continuing the mesalamine, with the only question being from an inflammation control? And I think that's very clear, is that from an inflammatory control, mesalamine's not offering added value at that point. But what the question that I don't think really know, because I think the data prior to this study had been like, it's so great, and then it was like, well, maybe it's not, is that, is there a chemo preventative aspect to it? It's such a low-risk therapy, but taking 4 tablets a day or even 2 tablets a day every day is pretty challenging, I think, for most patients.
The other point that I would add, I cautiously bring in basic science here, because that's even murkier than, clinical translational studies. The basic science tells us that it's actually not the chronic inflammation that's the problem. It's the acute episodes of severe inflammation. So even that patient who's been under good control for a couple years, but had 1 year of heavy, intense disease, lots of steroids, a couple hospitalizations, the belief is those acute episodes are probably what confers the majority of the genomic damage. And this is based on instability complexes in genomic DNA that are associated with cancers that are identified. And so this is very difficult to tease out clinically, but the layer that I would add is that, and this is personal anecdote on top of the basic science data I just told you, a risk factor that's not shown that I use is that acute, severe, brief episodes of inflammation. That weighs more heavily for my personalization of their risk of cancer than like the smoldering, chronic, low-level inflammation, like the mild patient where you just can't really get them totally in control. They're not sick enough for biologics. They're doing okay. I'm worried more about the patient that had terrible disease, even if they're fine now. And the pseudopolyps are likely a surrogate for that acute, severe disease that caused so much tissue damage.
That's great. Well, we are over, and I am keeping you from the beautiful weather outside. I do want a couple of housekeeping. Again, 7 a.m. with me in here. I promise I won't oversleep. If you were here last year, you know that every alarm clock failed in my room. But there is a 5 o'clock reception really highlighting a lot of the great science that our trainees, as well as our advanced practice provider attendees have done. So please consider coming by, grab a refreshment, walk around, listen to the incredible science that the state of Michigan trainees are doing.